Welcome, Dr. Gary Procop. Dr. Procop is the Director of Virology at the Cleveland Clinic Foundation, and we'll be discussing a few facets of virology germane to us as surgeons. Welcome, Gary.
Thanks. Great to be here.
Appreciate your taking the time and sharing some of your wisdom with us. Perhaps for those of us in the world of surgery as opposed to pathology and laboratory medicine, could you please explain a little bit about your background and what got you to your level of expertise with COVID-19?
Yeah, sure. And so I'm trained in anatomic and clinical pathology, and then did a subspecialty fellowship in clinical microbiology, and really have kind of lived through the era of molecular diagnostics being invested in the laboratory. And so run many different areas in the laboratory, but the one germane to today's conversation is clinical virology. And, as you can imagine, we've been knee deep in COVID testing for the last number of weeks.
Let's stay with the theme of COVID testing. Could you please explain to us some of the features of COVID testing? We hear about a variety of methods of testing. We hear about sensitivities and specificities, and I know you've addressed those sensitivities and specificities on a national level. Perhaps first you could talk about the different tests available and their levels of accuracy.
Right. So there are really, two tests currently available, two categories of tests currently available. A third will probably be coming out because we've heard Dr. Burke talk about it. And so for direct detection of the virus, actually detecting the virus itself, we need a nucleic acid amplification test, and that's going to be a RT-PCR for the most part. There's one isothermal amplification method out there, but those are going to be nucleic acid tests for direct detection of the virus. The other test that's gained a lot of popularity and is extremely complex in its use is serology testing. And you could have many webcasts just on that. It's so complicated. And then what will be coming next will be antigen testing. And that's what we've heard Dr. Burke talk about recently. Each of these tests have strengths and limitations. And I think as clinical providers, it's super important that you and your teams understand the limitations of each so that you can balance the idea of risk, both to yourself, with or without, say, N95 masks, and to your patients.
As we talk about N95 masks, theoretically, if a patient tests negative, assuming that test has sufficient sensitivity and specificity, the N95 mask wouldn't be necessary if the patient tests negative, and if they're positive, we assume it's a true positive. But just how likely are those scenarios, at least in the former, in the PCR test that you were describing?
Well, that's one of the reasons we did one of the studies that we did was, as these tests come out through emergency use authorization, no one really knows the true sensitivity and specificity of these tests. When we first brought this up, that was the question I was asked over and over again. And I had to tell people, we don't know, because how do you define a true positive for a brand new disease? And in order to validate these tests by the FDA's emergency use authorization, you have to do a number of studies with positive control material. And you get ideas of, you actually have to calculate your limit of detection. But how that actually translates into sensitivity and specificity in the real world is really not known. So we started this testing as best we could under the guidance that we had. But then once these tests had run for a while, we decided to undertake a study where we looked at 5 different tests. And this was really done for laboratory test development and quality assurance for our clinical providers and patients, to look at the sensitivity and specificity of each of these assays. And the way that we were able to do that, and we've done this many times in clinical trials, is we would define a specimen as containing the analyte, here containing the virus, if 2 or more of the tests tested positive. So you had a positive test that was corroborated by another test, often more than one test. If you had only a single test that couldn't be corroborated, that would be called a false positive. And of course, if they were all negative, that specimen would be called truly negative. So by having multiple tests to be able to compare one to another, we're able to actually determine whether the analyte's present in the specimen or not, and thereby determine sensitivities and specificities for each of the different assays.
What did you find were those sensitivities and specificities?
So they varied somewhat. And, to me, this is really important for clinical providers to understand that. So we tested two tests that were basically what you would really consider traditional molecular assays. They had full nucleic acid extraction as a front end, and then reverse transcription PCR on the back end. And both of those tests performed very well. The CDC assay was the assay we started with, and it had 100% sensitivity, 95.6% specificity. It was really our best performing test. The second test in that same category utilized primers and probes from a company called Tidmobile, and we ran that on the Roche Z480 instrument. And it also performed very well, 96.5% sensitivity, 98.5% specificity. The one rapid test that performed extremely well was the Cephia Gene Expert. And it had a 98.2% sensitivity and a 93% specificity. The other two rapid tests that fell below the mark that we wanted to use them were the Diasorin test with 88.7% sensitivity and a 98.6% specificity. And then the Abbott test, which has been on the news a lot as this quick 6-minute test. And it had an 84.5% sensitivity and a 97.2% specificity. So interestingly, the Abbott test, and all of these were done from the exact same clinical specimen. That was important for a true head-to-head comparison. Now, about halfway or 3/4 of the way through our study, Abbott actually changed its EUA, so now you can only test it directly from the nasal swab into the box. The challenge with that is you have no specimen left over. So if you think you have a wrong answer or a right answer, no way to confirm it. So we are looking to undertake that study relatively soon with a dual swab study. But when we started the study, it was valid to compare all of these from the universal or viral transport media, which is what we did. So to me, this is really important for clinicians because it determines how you'll use these tests most effectively, keeping yourself and patients safe.
Thank you. That's absolutely outstanding information. I believe information that everybody needs to hear. What are the rate-limiting steps to wide-scale testing? You mentioned keeping us safe as healthcare providers and keeping our patients safe, but what about the population at large? There's a lot of discussion about people who are asymptomatic wanting to be tested, and perhaps the justifiability and cost-effectiveness may vary contingent upon the incidence in a given geographic area, but I'd like your thoughts.
That's going to be very challenging. These are actually the types of tests that you really need to detect virus presence. So we know, and we actually have some data from this study, that the assays that are missing are actually missing people with lower viral loads. So if you really wanted to find people who were pre-symptomatic or asymptomatic that were recently infected, you would really need the most sensitive tests. And those most sensitive tests are just really not practical for such a wide scale distribution. So it's really a challenge. This is why people are interested in things like serology, which has a load of problems, and antigen testing. And so, I think the idea is, where do you want to use these tests and what are the risks associated with it? So for example, and we actually talked about how could we use these underperforming tests and it be medically acceptable. And so it turns out that if you use tests with really a suboptimal sensitivity, but in a low prevalence population, like asymptomatics, or we said, what if you use these in an outpatient setting where you're going to tell the patient to go home and really your instructions to them are not going to change. If they have an upper respiratory tract infection, you're going to tell them to self-isolate, stay 6 feet away, wear a mask when you're around people, etc. You could live with false negatives then. a challenge comes up if you're going to have somebody and you're going to put them into a situation where there's potential aerosolization, like intubation, for example. You would want the most sensitive test, in my opinion, to keep people safe, or you would just want to always wear the N95s. But according to our infection prevention specialists, testing should dictate the use of PPE. So to me, if you used our CDC test or one of the Cepheid tests, and we gave you a negative, it would tell the anesthesiologist they would be fine and the surgeons would be fine without the N95s. I would not feel as comfortable with one of the underperforming tests to give that information to the clinical team.
How important or unimportant do you think widespread testing is to fully reopening the economy?
I think to reopen the economy, we're going to have a combination of testing plus mitigation strategies. I think that individuals are going to be interested in opening if they can test from day one that all of their employees are negative. They'll feel comfortable doing that. But it's challenging with a respiratory virus because you could be negative today and infected tomorrow. So we can't test everybody every day all the time. It's just impractical. So I think it's going to have to be a combination of mitigation strategies, some type of testing, and other strategies like temperature taking, wearing of masks, etc. So I think it's just going to be a new world when we go out to restaurants in the future.
One last question for you, given your background as a virologist. We've heard that COVID-19, and we've seen with what's happened, it's elusive. It seems to, I don't know if it morphs and has different permutations. We hear that people may get infected, turn positive, negative, positive again. How is this virus different than other viruses?
Well, it's an RNA virus. And so one of the big distinctions in the world of virology is DNA viruses and RNA viruses. And there's a variety of reasons for that. But one of the most important reasons is the mechanism by which they replicate their DNA or RNA. And so DNA polymerase, which is used to replicate DNA viruses, is a high fidelity molecule that makes very few mistakes. RNA polymerase, on the other hand, makes errors all the time. And this is what is responsible for antigenic drift in influenza and why we see slightly different influenzas every year. This is an RNA virus too. So we would expect to have antigenic drift in this virus also. And so that's why, we probably will see differences in the future. And as vaccines come up, they'll probably come up in a way similar to how we approach influenza vaccines.
Thank you very much for your time, your clearly formidable expertise in the area, and your assistance with us in the field treating patients in surgery. Wish you and your loved ones sustained health and safety through the pandemic, and hope to see you in person at some point in the future.
It's been my pleasure.